Thank you for joining us today for the 5th Annual Policy Summit presented by the American Association of Kidney Patients. This year's summit is titled Patient Voice, Patient Choice, New Determinants for Kidney Policy. My name is Ed Hickey. I'm president of AAKP and serve as the chair of the Veterans Health Initiative. Professionally, I'm a veteran United States Marine Corps infantry officer. My public service career includes posts on Capitol Hill as an administrative assistant to a United States Congressman and a special assistant at the United States Department of Congress under George H.W. Bush. Following the terror attacks of September 11th, I also served as a senior advisor for Homeland Security for the Director of the United States Civil Service under President George W. Bush. Currently, I'm a practicing attorney in Los Angeles. I'm active in the armed forces legal community, working locally with the Veterans Legal Service Project of the LA County Bar Association to support the legal needs of active military personnel, reservists, and veterans. And at a personal level, I'm a fellow kidney patient. I'm also an experienced caregiver and patient advocate because of the history of kidney disease within my family. I'm pleased to introduce our session titled Critical Barriers to Care Transformation: How Payment Policies Impact Kidney Patient Consumers and Innovation Leaders. AAKP has, for over 50 years, been a champion for patient choice and innovation in kidney medicine, including therapeutics, diagnostics, and devices. That is why AAKP fights for solutions that help diagnose disease earlier, slow disease progression, and helps stop kidney failure. We are strong advocates for preemptive transplantation, greater access to kidney transplants for all patients in need, and home dialysis. AAKP defines high-quality kidney care as timely patient access to therapies that keep patients healthy and fully capable of pursuing their aspirations, such as maintaining a career in meaningful part-time or full-time work, starting a family, owning a home, and retiring securely. After decades of stalemate and little innovation, the kidney community is witnessing a golden era in kidney drug and device development. That is why, in part, AAKP declared the next 10 years is the decade of the kidney. In the past several years, the U.S. Food and Drug Administration has approved several new and safe treatments that help patients better manage kidney diseases and related conditions. AAKP anticipates more approvals in the coming years. These approvals require tremendous research, investment, patient participation in clinical trials, and advocacy. And to be clear, each FDA approval is a significant victory for kidney patients in need and the companies and researchers who have committed themselves to transforming status quo kidney care. Yet these victories are incomplete if patients cannot access the drugs and devices once the FDA has found them to be safe and approved for patient use. Patients, medical professionals in the industry are becoming increasingly frustrated by the cumbersome barriers to patient consumer access to the innovations patients have fought for decades. Some payers, including insurance companies, and at times the Centers for Medicare and Medicaid Services, or CMS, either intentionally or through a lack of understanding of the patient burden of kidney disease, erect barriers to access these FDA-approved treatments. In some cases, some payers do not support these innovations at all. AAKP believes access must be addressed now because access to future innovations will be negatively impacted if we are not successful in these initial fights. Fighting for patient access to new innovations takes courage, political sophistication, and the fortitude to win. This is why AAKP launched its Patient Voice, Patient Choice Initiative in 2022. Through this interactive platform, patients and care partners can quickly identify barriers impacting care, choice, and treatment. Through AAKP, patient consumers can engage elected leaders, government agencies, and payers to raise their voice when timely access to safe, FDA-approved treatments and devices are hindered by nonsensical barriers. Simply put, AAKP is 100% committed to making certain patients receive the right treatment at the right time based on the guidance of the doctors they choose to give them care. Our next speaker is well known across the kidney community, Dr. Alan Nissenson. Dr. Nissenson is a co-founder of Renal Care Innovation Holdings and a former chief medical officer of DaVita. He is an emeritus professor at the David Geffen School of Medicine at UCLA. Dr. Nissenson has served in many leadership capabilities within the kidney community over the past years. He has collaborated alongside past AAKP presidents Richard Knight and Paul Conway on multiple CMS technical evaluation panels to shape substantive patient-reported outcome measures under the CMS 5-star dialysis quality rating program. Most importantly, Dr. Nissenson shares AAKP's commitment to timely payment for and patient access to new innovations in kidney therapies that are becoming available during the decade of the kidney. Dr. Nissenson, it's a pleasure to welcome you to our summit. I turn it over to you.
Hi, I'm Dr. Alan Nissenson. It's a real pleasure to be able to be here today to present to the AAKP Public Policy Summit. So thanks very much again for the invitation. I'm going to spend some time talking about the barriers to innovation in kidney care and how we can overcome these and really move the needle forward. Just so you know, some of my potential conflicts here, I'm a partner and co-founder of a company called Renal Care Innovation Holdings, which works with new and innovative companies trying to bring products and new innovative care models to the marketplace for kidney patients. I'm also on the board of directors of several companies in the kidney care world, including Angion Biomedica, Rockwell Medical, and Diality Incorporated. We all know that the issue right now with improving the care of patients with kidney diseases is that we need to have more innovation and we need to make sure there's access to care. In the US, we spend a tremendous amount of money to treat patients with chronic kidney disease who are on dialysis, over $30 billion, nearly 7% of the overall Medicare budget, but only about 1% of patients in Medicare actually have chronic kidney disease and are on dialysis. In addition, there are nearly 40 million people in the United States who have CKD but aren't yet on dialysis. So what we really need to focus on are how do we identify kidney diseases early? How do we slow the progression of chronic kidney disease? How do we broaden patient access to kidney care choice that's consistent with individual patients' life goals? And how do we bring truly innovative products to market with appropriate reimbursement and payments? It's ironic that we are having a discussion in 2022 about innovation and the lack of innovation in kidney care. If you look back 10 years to 2012, in that year, the Kidney Health Initiative was launched, which is a very creative and forward-thinking effort to bring together public and private organizations to work on accelerating innovation in kidney care. Again, 10 years ago, very forward-thinking, nothing like it in any other medical specialty. Yet here we are 10 years later, lamenting the fact that we still haven't seen the kind of innovation in kidney care that patients deserve. And in fact, even more recently, programs like the KidneyX Innovation Accelerator, the project started by ASN and the Department of Health and Human Services to fund new research into kidney diseases. The AAKP itself in 2019 launched the Decade of the Kidney. The executive order issued by President Trump advancing American kidney health, again, happened in 2019. And the Kidney Care Partners Kidney Care First framework, which emphasized innovation, was also issued in 2019. Yet here we are, still not seeing the kind of innovation we would like to see. It's important to understand the context of innovation in kidney care and the scope before we get into the specific barriers to innovation and some of the potential solutions. So when we talk about innovation in kidney care, we really are looking at three separate areas. One is pharmaceutical discovery and delivery. Second, development of new and innovative medical devices that can be used by kidney patients. And third, design and implementation of transformative care delivery models. So what is the real contextual framework that we need to consider and that we need to make sure that potential scientists, engineers, innovators, and funders think about when they're considering working in the kidney care space? And this really represents the journey that patients with kidney diseases go through over the life cycle of their illness. One is early identification of kidney disease. Secondly, interventions to slow the progression of CKD. Third, addressing the complications of CKD, such as anemia or metabolic bone disease. Fourth, proactively planning and ensuring optimal choice of treatment plans. And that includes transplantation, hopefully preemptive transplantation, but if not, living donor or deceased donor transplantation, and various forms of home dialysis, as well as conservative therapy for those patients who choose not to get a transplant or to go on to dialysis. There needs to be improved in-center dialysis equipment and treatment paradigms for those patients who choose in-center dialysis. And at every stage, patient involvement and patient insights are critical. What are the barriers to successful innovation, and why aren't we seeing more innovation? First, it's important to remember that many of these barriers are common to the entire scope of innovation. That means pharmaceuticals, devices, as well as care delivery models. On the other hand, some are specific to pharmaceuticals and devices because in those two cases, regulatory approval is required, generally from the FDA. In the case of care delivery models, patients, physicians, and payers need to accept the new care delivery models if they're going to be successful. So what's the real elephant in the room here that's holding back innovation in this field? And remember that for innovation to take place, it requires dedicated, motivated scientists and engineers, as well as willing funders or investors to make sure that innovation truly happens. But what's holding that back? First, we have a very perverse bundled payment system, particularly related to the payment for end-stage kidney disease patients. And I'll say more about that in a minute. There's a lack of mechanisms to pay for new drugs and devices that improve patient lives. And this really relates to the bundled payment system. And that is, it's not clear that if a new drug or device is developed and is made available, that there will be any payment for that. So that is a huge disincentive for investors as well as scientists. Third, there's a very paternalistic view by the FDA and the need to protect the vulnerable patient with kidney disease. I'm going to say more about that in just a minute. And what it really represents is that for our population of patients, the FDA, whose charge is really to balance benefits and risks of a new drug or a new device, the FDA tends to weigh very heavily on risk and give much less credence or value to benefit, particularly if the benefit relates to patient factors such as quality of life, patient convenience, and patient choice. And finally, there's a lack of coordination between the FDA and the major payer, at least in the case of end-stage kidney disease, which again creates uncertainty about approval and payment, which discourages investment in this area. So why haven't we seen more innovation? A few of these points I've already made on the previous slide, but I do want to emphasize a couple of others. One, when scientists or investors think about the kidney care space, there's often a lack of insight about how complex this environment is. And I mean that patients, caregivers, including nephrologists, companies that provide dialysis services or other care delivery models, as well as payers, are all part of this group of disparate stakeholders. And often people who want to get into this area don't really understand this very clearly. In addition, there's very poor understanding of the key strategics in kidney care. And in this country, in the United States, the key strategics are DaVita, Fresenius, and Baxter primarily, and the concern of potential scientists or investors that if these large organizations, the strategics, don't approve of or don't accept whatever I'm working on, that I will be doomed to failure. So tremendous risk there. There's also very limited involvement of patients in product development, and I'll come back to that a little bit later. And the other items, which I've already emphasized on the other slide, relating to the current payment environment and the way that can disincentivize investors and scientists to innovate. So let's talk a little bit about the FDA, because at the end of the day, even if you overcome the initial barriers and you get scientists interested, you get investors interested, they work on a new project, a new drug, a new device. At the end of the day, the FDA has to approve the drug or device in order for it to move forward and ultimately get to patients. And I want to give you some examples of recent rejection of kidney drugs by the FDA. Tenapanor is a drug which can significantly lower serum phosphorus. It's completely different from the traditional phosphate binders, and it is already an approved drug for other indications. This drug has now been rejected by the FDA, not because it doesn't lower phosphorus, which it does, but because the FDA has decided to move the goalposts and to say lowering phosphorus isn't enough. The manufacturers of tenapanor need to demonstrate that if the phosphorus goes down, there is some demonstrable clinical benefit. And that is a goalpost movement that has never been required of another phosphate binder. The good news is there is another advisory committee meeting coming up on November 16th, which will discuss this drug again, and hopefully it'll get approved. A second drug is Vivaramir, which is a drug to treat metabolic acidosis in chronic kidney disease patients, very common condition, and has been shown to be associated with accelerated progression of chronic kidney disease and mortality. Again, clinical trials showed that when you give the drug, the serum bicarbonate does go up as expected, no side effects, but the FDA still wouldn't approve it because a hard outcome, namely change in progression of CKD, was not statistically significant. And at the bottom, I've listed 3 of the new anemia treatment drugs. These are called HIF PHIs. It's a new category of drug to treat anemia, different from Epogen, which is commonly used. And there's a 4th drug called daprodustat, which also was recently evaluated by the FDA. All 3 of the drugs listed here have been rejected by the FDA. The 4th, which was the most recently evaluated, has been a recommendation by the review committee, was 13-3 in favor of approving for dialysis patients, but 5-11 against approving for CKD patients not on dialysis. And the irony here is that the main benefit of these drugs is that they're given orally. So their major benefit is for home dialysis patients, but also for CKD patients not on dialysis. And again, they were rejected. And I say these are examples of the paternalistic attitude of the FDA toward kidney patients. And I want to illustrate that by showing you, the other day I was watching TV and I just wrote down some of the drugs that were being advertised over a couple of hours when I was watching, and I've listed them here. And again, all of these are FDA approved. All of these are for non-life-threatening, although unpleasant medical conditions. And all of these, if you look at their package insert, have very similar side effects to all of the drugs that I showed you on the previous slide that have been rejected by the FDA for kidney patients, such as allergic reactions, anaphylaxis, worsening heart failure, vascular clotting, GI bleeding, and mortality. So for some reason, our drugs seem to be scrutinized to a much greater extent than many other drugs that are evaluated by the FDA. So what's the typical approach when an entrepreneur, the scientist, or a funder wants to develop a new drug or device? First, they identify a gap in care. They identify a product that could fill that gap, that create a pitch so that they can get more investors. Then they modify what they're doing to fit the potential investors and make sure they can get money. They try to raise financing through capital markets. They work through clinical trials very aggressively to get FDA approval, and then hope one of the strategic partners will acquire the company and see that it's commercialized. And why doesn't this work? Well, unfortunately, the people who are going through this process generally have inexperience in the execution of clinical and business plans. So there needs to be a focus on patients and patient needs rather than the needs of the investors or the demands of regulators. There's an underestimation of the funding required really to get through all of the processes that will lead to availability of a product for patients. And there often is a lack of executive leadership in these companies that are trying to develop innovations. And the result is the approach I outlined often doesn't work. So patients are generally not involved. There's a fundamental gap in insights about the complexity of kidney care. There's a lack of understanding of the needs of stakeholders. There's a challenge which often can't be overcome of engaging dialysis organizations. There's poor understanding of other key strategics in the area, and then challenges because of the payment system to full commercialization. So what can we do to drive innovation? So the story isn't all bleak. There are things that can be done. Once we understand the barriers and the challenges, then there are things that can be done. First, engage the general public as well as patients with kidney disease in their insights in all aspects of innovation. So get some additional public relations around the burden of kidney diseases and the potential for innovative products and delivery approaches to improve the lives of patients. Secondly, articulate the narrative of the clinical journey of patients with kidney disease. And that way we can better understand the current gaps in kidney care innovation. Third, try to identify innovations that will make a difference in the next 2 to 4 years. So look at the time horizon. There often is a tendency to look at long-term solutions, at grandiose innovations that might take 10, 15, 20 years to be achieved. But we need to look at what are things that can be done in a short time frame that can be applied to improving patients' lives. And finally, educate key health science investors in opportunities to improve kidney care, and that will also produce a fair return on their investment. And I just want to emphasize that involving patients right from the beginning of conceiving of an innovative idea and through to the end, which is development of a product, is critical. On the right-hand side of this slide, you can see what patients say are things that really are difficult for them and that they focus on patients with kidney diseases. But on the left-hand side, and this list was provided to me by Paul Conway, we've listed the really high-level things that are important to patients and that should be considered when any innovation is being developed. What are the medical health implications? So how will my primary condition or comorbidities or other conditions be impacted by this innovation? What will the impact be on my family or caregiver? Will this add to or relieve stress on my family, on my children, on quality of life for them as well as for me? How will it impact my employment or my ability to be employed and to make a reasonable income and maintain mobility in the workforce? And finally, how will this innovation align with my aspirations? Will it align with my life goals, things such as travel? Finally, a couple of words about the FDA, since I spent some time talking about the challenges and the disappointments we've had working with the FDA. But there is a way forward, not only by working through the Kidney Health Initiative, which includes representatives of the FDA, but also by working with the agency to emphasize benefit of innovations, by working with them to create formal patient preference studies so that patient preferences are a key part of the evaluation process, by looking at how disease burden is addressed by the new innovation, by looking at patient experience data, by having patient-focused drug development meetings with the agency, and to use real-world evidence to support applications, meaning talking with current patients. In terms of study design, and this is a burden on us as investigators or as developers, we need to incorporate patient-reported outcomes into our clinical trials. We need to have frank discussions about whether hard outcomes always matter or whether intermediate outcomes, for example, lowering of serum phosphorus or improvement of quality of life, should be enough. And this is my final slide. What else can we do to drive innovation in kidney care? We need to talk to the external world, including potential funders, and articulate the rewards of investing in kidney care, along with some of the intangibles. So it's not just financial awards, but also name recognition to try and get angel investors to be early investors in new ideas. We need to have better collaboration of key advocacy organizations, AAKP, ASN, RPA, and others, to create legislation that better authorizes reimbursement for new devices and pharmaceuticals outside of the dialysis bundle. There are transitional payments for drugs and devices now, but they're very short term and really don't help to a great extent to encourage investors to invest. We need to widen efforts to work with other key federal agencies to leverage their experience in driving innovation, and then hammer home the message that new care models, not just drugs and pharmaceuticals, that are created on the basis of patient care choice, value-based care, and fair reimbursement are also innovations and are just as important as drugs and devices. Thanks very much for your attention to this presentation. It's been a pleasure being a part of the AAKP Public Policy Summit, and I hope to see much more innovation in the future to greatly improve the lives of patients with kidney diseases. Thanks very much.
Thank you, Dr. Nissenson. For someone immersed in the kidney space for decades, your insights and expertise on aligning payment and regulation to support innovation is invaluable.